Hi, SHSU students. This is Dr. Craig Murphy coming to you from the office, and I was going to give you a pre-recording of the ultrasound needle guidance session that we're going to be doing with clinical skills next week, and I wanted you to be prepared for that. So as we start looking at our abilities to scan, we're going to want to think about what happens at each ultrasound station. So you're going to have multiple stations, but when you come to the ultrasound component, there's going to be 4 machines and multiple faculty to help you out with this process. We're going to do a flipped classroom, so you have to have watched this video and paid attention to what we're going to be trying to accomplish. And if we find that you're not, because our timeline is so tight, we may have to deny you access to the training and catch up some other time. This is competency-based and skill-based learning. We're going to give you a little bit of information on MSK and needle guidance so that you have the information you'll need to be successful. And when we go to those stations, we'll essentially get started right away. I'll be producing some phantoms to bring in to target either a vascular-looking structure or a specific target within a phantom. I would ask that you'd be very careful with the homemade phantoms, because if you apply more pressure, the probe itself can dig it up. We don't want to inject anything into the phantoms because the air will ruin it for others, and we're just going to be targeting. We only have about 20 minutes of skill time to get through 4 or 5 people, so that's only a few minutes per person for scanning and needling their target, which should be enough if you've paid attention to this particular presentation before you get into the lab. So what would we want you to accomplish? Well, we want you to capture a long axis entry into the target and into a trainer, and then we're going to do a short axis entry into the target. What we want you to do with the short axis entry is we want you to save the short axis entry onto a screen to show that you're in the target. Then we want you to go and split screen, which will show you those buttons, pivot your probe, so that's a probe manual handling skill, and then show us the long axis that it's actually in the target as verification. And this is what you would typically do in the clinical setting. Enter in short axis and confirm with long axis. Now when you start thinking about where we're going to be doing all of this targeting, it oftentimes is associated with MSK, so musculoskeletal ultrasound. And there's 5 common artifacts that you'll see in MSK. One is something you've already been introduced to, which is anisotropy. Anisotropy or anisotrophy is when the structure you're looking at, oftentimes tendon, looks anechoic, even though you know that that's not really true. It's not a fluid structure, and there's just no sound coming back from that area because it's bouncing into space and not making it back to the probe. Oftentimes you can get rid of this artifact by changing your probe angle to match up in a more perpendicular way with the structure you're scanning. Acoustic shadow, you've been introduced to those as well. So that's really 3 types of shadows that we'll talk about, but we're talking about bones and something that absorbs all the sound. That's going to be an absorptive shadow. You can have a refractive shadow, which is very similar to what you see with light, where it bends the sound around the edge, so there's nothing else coming back from it. So that is sometimes known as a edge artifact. And then, of course, you can have things that will eventually attenuate structures all the way down, and you end up with a scatter shadow, which happens with air. Posterior acoustic enhancement, or PAE is the short form for that, is artifact that looks to artificially enhance the signal behind a fluid structure, and that's a result of less attenuating energy from fluids than there are tissues around it, because the fluids are more elastic compared to, let's say, liver or connective tissue or even muscle. So you'll oftentimes have an enhanced energy behind a vascular or a fluid-filled structure. Posterior acoustic enhancement. Cartilage interface sign is something you'll see if you're doing injections on a joint, and this would be what you'd want to find. So that hyaline cartilage, hyaline means glass-like, so it's a very good reflector, just like a mirror is made of glass. It's a good reflector of sight, so we get a nice accurate image of ourselves when we look in the mirror. When we look at highly glassy structures like hyaline cartilage with sound, it's also a good reflector of sound. So it is what's known as a good specular reflector. And therefore, when we're perpendicular to it and we have the sound coming back from the perpendicular edge of the cartilage, then we can see a little interface sign that tells us where that cartilage starts. We don't see it around the edges all the time because you end up having an anechoic component around it because it's not bouncing back to the probe. Reverberation is a really big term. Ringdown is a little bit more specific type of artifact that falls under the umbrella of reverberation. Technically, everything we see coming back to the probe, we can't see without reverberation. It has to come back to the probe to be interpreted. But reverberation and ringdown, we'll see these repeating intervals. Oftentimes, it's when it gets stuck between two reflective surfaces that are good specular reflectors, and the sound bounces back and forth, back and forth. And then it takes time for it to bounce back and forth, and then eventually it escapes to the probe. And because it took time, it puts it deeper into the image. So those are things we'll see. Let's look at those as examples. Here we can see the tendon of this particular biceps tendon, or this is actually supraspinatus tendon here. You can see that this tendon coming across here is at an angle to the probe, which is up at the top of the screen, at the top of the box, and all of the sound is hitting it at an angle and bouncing back and never getting to the probe. When it's more perpendicular, these two yellow arrows here will get back to the probe. Now, if we look at the structures of anisotropy, that happens when there is a probe that's not perpendicular to an object. Why do we see it around tendinous insertion points? Is because they kind of beak into their attachment on a curve. So we have less sound returning to the machine at that particular location. It looks like there may be an inflammatory response here in this shoulder tendon, but that's not real. It's anisotropy, and you would not want to clinically overinterpret that artifact. So you have to understand that one very carefully. Change the angle of probe, change the perpendicular probe angle to that tendon, and it would look just like the tendon that's more towards the receding edge. You've already seen this picture when you were introduced to the idea of anisotropy. And in one view, the probe is nice and perpendicular to it, so it looks like a normal tendon. But if you change the angle of the probe, where you're getting poor visualization, you can see the ligament over top of the bicipital groove, but you can't see the biceps tendon underneath of it because it's anisotropy. You would not want to assume that that was a cyst-filled structure. You simply move the probe to get rid of that artifact. Here's the shadowing that occurs. So in the top, we can see a gallbladder, and that gallbladder has a stone in it, a gallstone, which is creating an absorptive shadow. So it's very bright on the leading edge or the superficial edge of that gallstone, and everything deep to that gallstone is being shadowed because of an absorptive shadow. When we see the lung here in the middle picture, it's hitting the surface of the lung, and it's scattering the sound all over the place like disco balls, so it loses energy by scattering it everywhere since it's just a small reflector air particles, and it attenuates into this gray headlight look very quickly. So that is called a reflective shadow, or sorry, a refractive shadow. And then the bottom one, where we can see this fluid-filled vessel with kind of a shadow on the edges of it, that's the edge artifact, would be the other term for that one, and that is refracting the shadows out of the way. So it's bending the sound. What we can see here is a cystic structure, and we can see blood vessels in the neck in the bottom image. And when you look at each of those, the bright signal below the cystic structure or fluid-filled vascular structure is a little bit more intense than you might see right next to it, because there's more attenuation through the soft tissues than there is through the fluid. and that's why we get posterior acoustic enhancement, so that when it finally bounces back to the probe, it's actually carrying more energy, so the pixels at that depth are going to be a little bit brighter because of the intensity of the signal returning to the probe. Finally, the fifth one we're going to see is that cartilage interface sign. And here, right at this arrow, you can see a thin line with a hypoechoic component or even anechoic component underneath of it. That would show you the thickness of the cartilage along this person's humerus, which we're seeing. So we know that we're along the head of the humerus because there would be articular cartilage, as opposed to being over top of the neck or over top of the insertion points of some of the tendons where we would not see hyaline cartilage. When we get to the one we'll see during needling, the reverberation is the one we're going to think about. And now you can see these repeating lines under the real needle, which is the bright signal of this nice straight metallic object. But inside the tube of the needle, which is hollow, it bounces back and forth until you see the reverberating lines going deeper and deeper and getting less and less signal intensity because of the attenuation from the time it spends bouncing back and forth. So when the sound comes down, gets through the tube, bounces back off the wall, and then escapes back to the probe, that would be the first line. If it bounces back and forth twice, second line. If it bounces back and forth 3 times, third line, and so on and so forth. So that's why we get this ring down artifact, especially from metallic needles. That helps us to see our needle. So we like this artifact when we're doing needling. And you want to get refraction and reflection back from this particular foreign object so that we can track it and do needle guidance. Now let's think about clinical scanning. As we start to add the repertoire of having access to these larger laptop-based machines, we need a few things we want to think about. From a clinical scanning order of operations, you always want to set up a scan first. So you would have equipment, patient information, presets, and ancillary tools. Get that all ready first. Set up your machine appropriately. Then you're going to create the scan by gathering information. So you put your name on the screen, an indicator of what you're scanning. Since there's no such thing as anonymous scanning, are you using a protocol? Are you doing a complete scan? Or are you just going to do some basic stuff like focus scans? At point of care ultrasound, we tend to concentrate on focused scans. They're not complete. That's what the sonographers would do. You as clinicians are going to be what we would call sonologists. You're using this as a tool as part of your clinical acumen. Finally, we would have the archiving of information. You always want to save something to show that you did what you said you were going to do, or save some proof that indicates why you made the clinical decision and the intervention that you actually made. Good idea to save clips because they tell you motion, save multiple images, and maybe even across multiple planes as you get out there into the real world. We may only ask you to save 1 or 2 images for curricular components, but in general, save what you think you need to save. Better safe than sorry, so they say. Things you want to set up when you're doing needling is that you want to get the machine set up so that you have good ergonomics. So for instance, these tables in the lab are going to be fairly short, so we're going to have you seated while you do this. In most situations, when you're putting a needle in somebody, because of its invasive process, you're going to be using sterile technique. And even though we're not gowning and gloving here, the reason we were going to practice assuming that you can't touch the machine is we're going to have one of your partners busy. They're going to run the machine, and you're going to have to use your words to tell them what you want them to do. Increase depth, decrease depth, change the focal point, turn up the gain, all those kind of words that you're going to use, assuming that you can't touch the machine. Notice how in one view, the person is across from it. So look at how the head goes strictly up and down from the target to the machine. That's what you want. In the other video, you can see how the head is moving side to side. And this, when you're pushing a needle, will cause you to drift, just like the first time you were learning to drive and you did your shoulder check and drifted out into the highway. because you didn't keep your hands running straight while your shoulder and body were starting to turn. So you always want to have good ergonomics. Make sure your body and head are aligned with the machine, so it's just straight up and straight down. Look up, look down, not to the side. You want good lighting in the room, so we'll start to pull down the lighting in the room if we can control that. You want to have a nice stance to it so that you're not going to be in any uncomfortable position that will also make it hard for you to rotate your body. And sometimes this is unavoidable, the way that hospital rooms are organized. But if possible, you want to make sure that you align things and have a good stance. Lift the bed up, or maybe lift the table up if that's a possibility, so that if you're tall, then you need to have it higher. If you're shorter, maybe you need to have it lower, but make sure it's in the right position to make this as easy as possible. Don't make it more difficult than it need be. Now, these are the machines, and you haven't really had a chance to be introduced to them at this point, but I want to remind you about a few things that you'll use. And if you go to any machine and you can find these particular issues or structures or buttons, then you'll be able to know how to operate the machine to make something of clinical relevance. The first thing is the on-off button. It's just like a computer, and nothing will make you feel as silly as if you go to a machine and go, oh yes, I've been doing ultrasound at my school for 4 years, but you don't know how to turn it on. So you always want to take a look around for that on-off button really early on. While it's booting up, you start looking around the screen for other important things. Typically on a laptop machine of any sort, you'll have patient information and presets. Patient information is because you want to set up your scan first as one of your order of operations. And the presets are kind of like getting you close, right? So we know we want to do shoulder scans, and it will set the depth and the brightness and all of those components to be what you might need for a shoulder scan or a knee scan. So presets will get you close, but you still need to fine-tune the settings of the machine to get the best images that you can with every image you take. The time gain compensators, TGC. This is going to be the top ones controlling the gain across the top of the screen in the superficial zones. And as you move down that series, you're going to have the lower ones and towards the mid of the screen that will actually control the bottom of the image to change the gain. Because when you have time, gain starts to attenuate with sound, just like distance starts to attenuate sound. So when you get it taking longer time to bounce back from the organ you're scanning, it therefore puts it deeper into the image. Of course, the gain, this is a roll. When you increase gain, you roll it to the right, and you decrease gain, you roll it to the left. Set, this becomes your mouse click button. So when you use your trackball in the middle, you might put the cursor over something or a measurement tool over something, and then you want to lock that in, you click set. Or when you're putting patient information, you want to lock that information in. Freeze, pretty obvious. Save, pretty obvious. One thing about the GE that you should know, though, is if you freeze it and then save it, it will save a still image, just a simple frame. If you just press save without pressing freeze, it will save a clip or a video. Depth, this is again roll, increased depth is going to be to the right, decreased depth is to the left. Of course, I always go the wrong way. That's just good Murphy's rule. And there's our split screen button. So if you want to activate the left side of the screen, click the left side button. If you want to take a picture on the right side of the screen, click the right side button. If you're not careful which one is active at the time, you can lose your image though. So be cautious to look and see, is there anything that changes as I flip from left to right side on these that will give me an indication which one is my active shot. And then we'll want to change focal point. This is something that you haven't had a chance to play with on your handhelds because it doesn't have that ability. The focal point on the handheld is set automatically to the center of the screen. So that's going to be your sweet spot where you want to try to put your anatomy of interest when you're scanning. But on these more expensive laptop machines, you have the ability to change the focal point. And the focal point really refers to the item that you're interested in clinically. So if you're scanning a heart one day, you might be looking at the papillary muscle and notice that the valve moves funny. And so you'd change your focal point to being at just at the bottom of the valve. But if it changes all of a sudden to the aortic valve, then you might move your focal point up towards that aortic valve because now you've changed your focal point. You can't do that with a handheld. It's always locked in the middle point. So just in general, the focal point should always be set just under the object of interest. And just in general, the most important thing that you get as close as you can on is the depth. You want to have enough depth to make the decision and a little bit of extra underneath the object that you're making decisions about, but not so much depth that you're losing resolution because of it. Remember, there's 4 anatomies to keep straight when you're learning ultrasound. You have the anatomy of the screen, and here we can see an ultrasound screen. Remember, there's going to be a probe marker side, and that probe marker by convention should indicate the right side of the patient, or if you're in long axis, the head of the patient. Then you have the leading edge, which is the probe marker side. You have your receding edge, which is the side away from the probe marker. And the reason that this is important is if the thing that's closest to your needle is the receding edge, then you'll expect to watch your needle come in at the receding edge side. If your probe marker is closest to where you want to insert your needle, then you'd expect the needle to come in from the other side. So you're watching the right side. The superficial half above the focal point is called the near field, and the other half of the screen, the deeper half, is going to be the far field, and it's the focal point that helps you divide where those are. And remember, then we've got the anatomy of the probe itself. So we have a probe marker, and we're going to put that probe marker to the right or the head of the patient by convention. And the probe marker side is sometimes called the toe of the probe. That means that if it's a foot, then the back side or the receding edge of the probe is going to be the heel. And you always want to line those up by putting the base over top. So what's at the top of the screen is the base of the probe, the thing closest to the probe. And remember, we're now looking at the probe marker, which is on the left side of the screen, and that would be equivalent to the right side of the patient, or if we're in long axis, remember that could be the head of the patient. And then we, of course, have the part with the cord coming off of it, known as the tail of the probe. Then you already know the anatomy of the patient. They have a left side, a right side, a cephalad, and a caudal, and they'll have anterior and posterior. You already know those. But what about if you're scanning something like the gallbladder? You have to consider the anatomy of the organ, or the thyroid, or the cyst that you're looking at. What is the origin of that? So you can have the long axis or short axis of the organ, which may not align directly with the right side or the head of the patient. So you have to know what you're scanning. Once you know what you're scanning, then you can start to think about things like the imaging of the structure and how the probe is oriented. You can do what's called a short axis view or a long axis view. So if we're doing vessels of the neck, which I know you've looked at, here you can see the screen, and you can tell that the carotid artery is towards the thyroid, which you can see here, and then the trachea is this air-filled structure in the middle, which you can see right here. This is all trachea, so that's air with a scatter shadow. And that means that if this is towards the right side of the patient, and this is towards the midline of the patient, this must therefore be a right internal jugular. So you would want to add that annotation to your screen. And there's no such thing as an anonymous scan, so here you can see this would be Craig Wayne Goodmurphy and a scan number or student number or a patient, or your employee number when you're in the hospital. No anonymous scanning. If you turn the probe along that right IJ, then you could get a long axis view, which is what we see here. And again, we should label that it's the right internal jugular and that there is a person who actually scanned this. Now, if you looked at this, you could know that this is towards the head by convention, but there's no way you would know if there was a right side from the left side without some more information. So that's why you always want to label the sidedness if they're different, the structure you're trying to get, and who did it. So we have our short axis view of the vasculature and our long axis view of the vasculature. These particular ones tend to add together with the anatomy of the body, but a gallbladder wouldn't necessarily align with the right and head of the vessel. So now we're going to have a needle coming in, and what I want you to see is that this one is towards the probe marker, so it's coming in from the leading edge, and there we have, notice how they pull back a little bit, and you can see that they just flushed a little bit of fluid in here, and you get this ring artifact as a result of that. We are not going to be pushing any fluid into these, okay? Let's watch that one more time. So here we can see that we're in plane with this particular one. Here's the probe marker side, so it's coming in from this angle. If they were putting the needle on this side of the patient, the needle would come in from this side. And they have to do a little bit of geography. What you can see here is that this whole thing is 3.1 centimeters, so that means that this is about a centimeter deep to the top of the vessel. And so they've got to have a needle that's long enough to get 1 centimeter deep at the middle of the image underneath this long axis view of this vessel. Okay, what's going to make it easier to see that needle? Well, you want to keep the bevel up. In this example, they did not keep the bevel up, but you can see it better when sound reverberates off that bevel. Parallel to the probe, so you want to keep the needle in the center mark of the probe. Look for the little center mark on the toe side of the probe, or in the middle on the heel, on the foot of the probe as well. There's a midpoint. And then you want to have echogenic needles potentially as well. These are a little bit more expensive, but they're designed to give a better reverberation and be easier to see in ultrasound guided procedures. And then finally, the bigger the needle is, the easier it is to see as well. But that may not always be appropriate, so you have to pick the clinically appropriate needle. If we were to do a short axis view, now we're coming straight in from the midpoint on the side of the probe, and they're picking, see how it's moving, and always following the tip into the view. And when they push, there's this little movement to it, which is called a chicken peck, and it's good to do that because that will help you understand that even though you might not see the needle, you'll be producing movement in the tissues around it that you can see. So this is known as an out-of-plane view because you're coming across the plane versus the other one, which is the in-plane view. The long axis is in-plane view. This is the one that you would use more commonly when you're trying to target a vessel, but then you might turn long axis on it, which is what we're going to ask you to do to verify that you're in the long axis. If you're having trouble with this particular view, go back to the long axis view. It's a little bit easier to start on, and make sure that you practice that one first. What you want to be careful of is that you don't miss the tip, because it will only come through your viewfind very quickly. So have your partner even help by watching the screen intensely, and when they see that needle come in with your insertion point, they would yell tip, and that way you would be notified that it's in the screen and not to lose it. You don't want to mistake the tip of the needle for the shaft of the needle. They look very similar sonographically, and that means that the tip is somewhere, you just don't know where, which should put your sphincter tone up. When it comes to color flow, we probably won't have a chance to do that considering we're using phantoms that won't have flow. But if you're looking at something in a real person, and you're not sure if it's cystic or if it's got flow, you can use color Doppler to help you distinguish not only if it has flow, but what kind of flow. Is it a cyst or is it a vessel? Because you don't want to go trying to drain a vessel. When you're thinking about Doppler, just as a tip that you want to remember, Remember, it uses math to figure out which way the sound is coming. Blue is coming or going away from the probe, and red is coming towards the probe. But it uses trigonometry. So if you think back to your trigonometry, when you're directly perpendicular to the flow of the vessel, it's 90 degrees to the flow, and you have a cos of 90, which is equal to 0. So if you have the probe angled a little bit and the probe is, the fluid is going away from the probe, it's going to have the Doppler effect, make it look blue. And if you're at 90 degrees perpendicular to it, then you're going to have anechoic vessels. You won't get any color flow. So if you angle it so that the vasculature is coming towards your probe, it will show up red. And that's going all the way back to the trigonometry associated with cos of 90 degrees. So we want to set up the machine and the materials correctly. We want to take an athletic stance and be in line with our target and the screen by setting up the machine and the target or patient appropriately. Set the object that you're trying to target in the middle of the screen. Do some geometry to think about estimated point of entry and the point of penetration. A little bit of hypotenuse calculation there. Make sure you have a needle that's long enough to do it. And then as you enter into the trainer or into the person, you want to keep your bevel up so you get good echogenicity. You want to be in long axis so it's easier to see the needle, or short axis so that it is a little bit more easy in dangerous areas to make sure you don't go somewhere else. And then the shallow angles will give you better reflection. And if you move the probe, now a chicken peck, remember that's kind of like an oscillation without advancement. Okay? Chicken peck is to create movement, not to push the needle through. And then want to always keep that needle in view. If you don't know where the tip of the needle is, stop and replace. Remember, you don't want to run with scissors or fried bacon if we're talking about tips either. Okay. A little bit of silliness, things that are serious. Safety tips. We do not want you handing the needle to anyone. They can get the needle themselves and it will stay inserted into the safe areas of the probe or covered until they're ready to use it. Don't hold the needle until you're ready to insert. Okay? You acquire your images with the probe only, and you'll want to do it with your non-dominant hand so you can drive the needle with your dominant hand. So left-handed probe manipulation, right-handed needle would be the typical. Don't inject anything into the trainers, especially not air. We'll keep a little bit of fluid in the syringe so that if you accidentally push that plunger forward, we won't push air into it. But please be careful that we're not injecting it. We'll ruin the trainers. You definitely want to keep that needle and the syringe full of water so that we don't have air tracks into the trainer. It will last longer. We want to position the needle in the trainer when it's not in use so that it's safe in the corner, one non-useful corner. And then after we're done, we want to make sure that all needles go into the appropriate sharps container. Don't worry about that. The faculty will take care of that one for you today. All right. That's what we've got so far. I want to thank you for doing your preparation on this. Hopefully we'll have a lot of fun with this event. We've got some upcoming events for some extracurricular scanning opportunities. Just as extracurricular, we're going to take 32 spots. Your ultrasound club leadership will have some more information about it, but here is looking at a few of the dates and what we're intending to scan at each of those dates. I'm Dr. Craig Goodmurphy, and I'm looking forward to seeing you in the lab.